Welcome. I'm Wendy Edelberg, Director of the Hamilton Project, and I'm pleased to welcome you on behalf of my colleagues at the Hamilton Project at Brookings. We are delighted to be convening experts to talk about urgent challenges to the healthcare supply chain. If you have questions for the speakers throughout the event, you can tweet them to us at Hamilton Proj with the hashtag health policy. Also, we're excited to be releasing a new policy proposal today. That policy proposal recommends policies that align the incentives of hospitals and manufacturers to foster greater quality and reliability of the drugs administered in hospitals. We will dig into that in a panel discussion in a bit. But first, for our fireless fireside chat, let me welcome Zeke Emanuel and Mark McClellan. Zeke and Mark will offer ideas on how the federal government can get the best of the private sector when it comes to creating and supplying pharmaceuticals. And they are the perfect people to do this. Zeke is the Vice Provost for Global Initiatives at the University of Pennsylvania, and he serves as a special advisor on health policy at the Office of Management and Budget and at the National Economic Council. Mark is the founding director of the Duke Margolis Center for Health Policy, and Mark is a former administrator of the Centers of Medicare and Medicaid Services and a former FDA commissioner. And I should say, I think Mark is going to have to leave us slightly before our conversation is fully ended, so don't be alarmed. It's all planned. But let's start just with a basic overview. The FDA reported at the beginning of this year that roughly 125 drugs were in shortage. That may not sound like a lot, but many of those are the most widely used, like saline, morphine, epinephrine, more than 20 shortages at any given time. All right, so Zeke, let's start with you. Can you help us understand what is currently happening in the market for pharmaceuticals, and what role does federal policy have to play here? What role has it played in the past?
Well, federal policy, and not just FDA policy, we should say it's broader than FDA policy and has often included tax policy, is absolutely pivotal in a lot of these issues. When I left government service in the summer of 2011, the very first op-ed I was able to write was all about shortages of cancer drugs at that time, creating the need to ration care. That's 12 years ago, and we haven't made progress. In fact, we've slipped behind. We have more drugs in shortage. We've known about this problem. It's not like it's suddenly new. I would say that a large part of the problem, especially on the generic side, is we have low prices, which disincentivizes investment in resilient production facility. It incentivizes shifting production to the absolute cheapest place, and that's been India and China. And I think that has created both a wobbly supply chain, questionable supply chain in terms of good manufacturing practice. And as I've written, I think one of the major issues there has been the changes in taxes related to Puerto Rico. And it used to be way back when, 25 years ago, we had a lot of production in Puerto Rico because there was a big tax benefit to doing that. And so we have a number of factors. The last one, of course, is FDA inspection of foreign facilities. And that it's just harder to inspect China and India, especially during COVID. And so we've got a combination of problems that have come together, tax problems, FDA problems, but they've been here for a while. And what is frustrating is the fact that 12 years, it's a long time to take action, and we really haven't done anything.
All right, so Mark, what should we do? If we gave you control of the magic wand for a day, what should we do to fix these problems?
Yeah, it's a great question. And I think it actually goes back longer than 12 years. I was FDA commissioner in the early 2000s. In 2003, 2004, we were dealing with some of the same kinds of drug shortages related to these products that are critical products. What they typically have in common, as you all mentioned, is they're injectable drugs that are no longer on patent protection. That means anybody who's up to standards in theory can manufacture them and supply them to the market. And in general, generic drugs have been great for the United States, for the pills that people take. A huge share of prescriptions now are generic drugs. We have, for the most part, some of the lowest prices in the world. There's some tweaks we need in our policies there to make sure that continues to happen. But it's worked out really well. So why not in these areas? Well, it's more complicated manufacturing. When you're talking about injectable drugs, you have to maintain a high level of sterility every step in the way for the projects. There's more quality control needed to make sure that the concentrations in the bag are right and there's no degrading and things like that. And as Zeke said, that means more expensive manufacturing. Also, the ingredients, have to be sourced properly, just like with any drug. And put that against the payments for these drugs. And we've heard a lot of critiques recently that it's not just a matter of, for the FDA being able to do the inspections and let people know that these are in fact, high quality manufactured products. But on the demand side, I guess you could say, are the purchasers of these products willing to pay the price? These purchasers are often hospitals who are needing these projects for their cancer patients with to get effective and timely treatment, for doing major operations to control pain, to help with anesthesia, to help with patients who need help with inflammation, like corticosteroids have been in shortage from time to time, injectable corticosteroids. So these are like really critical products. So why can't we do better? And there are at least some good examples, and maybe I'll start with that, of ways to get around this problem. There are now a number of manufacturers that are trying to adhere to very good practices for sourcing reliable active ingredients, for following the FDA's latest guidance, not only on reliable manufacturing, but continuous manufacturing and manufacturing lines that could shift relatively quickly from one product to another. Again, you got to be super careful about any kinds of infection or contamination for these injectable products in suspension. Examples of that include Civica RX. Premier is working with some manufacturers of these products. It does cost more money. Another example is Mark Cuban's Cost Plus Drugs, where they're trying to offer these products more reliably. They're still very inexpensive compared to, like, we're not talking about $10,000, $100,000 cancer drugs here. We're talking about $50, $60, a few $100s, maybe, if they're manufactured more reliably. So it's not real expensive, but it's more expensive than the sort of spot rate on the market. But for that to work, it not only requires the manufacturers that are meeting the standard and allowing FDA to inspect and providing the data that FDA already requires around letting us know if there's a shortage, et cetera, and maybe some additional information. It requires buyers. And while Premier and Civica RX have found some health systems that are willing to pay extra to get into long-term contracts, or to provide these drugs over, or to get into contracts that basically provide more guarantees that they'll be reliably available and have the data to back it up, that's not the case with most of the U.S. healthcare purchasers now. And that's where we're seeing some debate on the demand side. So policy options here, I'm oversimplifying a lot, but include providing more regulatory oversight and more transparency around how good the manufacturers are. Is their supply reliable? Have they kept their lines online and up to date? Are they using high quality manufacturing? And maybe some further FDA enforcement actions there. That's going to be a bit more expensive. And how do you match that with the willingness to pay for that somewhat higher level of quality and do it efficiently? So we don't want to spend unnecessary excess costs in these areas, but are there some good model long-term contracts that healthcare organizations could be that could implement? And can we track whether they're doing that? Is that something that CMS should look at? Are there changes in our pricing for some of these drugs. So some of these drugs are covered under Part B. They have a very low rate. If there is a need for increasing supply, if you increase the price now, you got to pay inflation penalty on those drugs. We need some way of refining those Part B payments for these drugs are used in outpatient setting. A lot of hospitals say, well, we're just being paid on a flat fixed DRG basis. So, it's tough for us to pay a bit more for these drugs. I gotta say, I'm a little bit less sympathetic there for most hospitals. Many of these hospitals are getting very expensive cancer drugs with things like 340B pricing, where they have like a huge markup on those drugs. So maybe just a case where maybe we need more transparency on that side. Is your hospital using a reliable supplier of these drugs? And is that something that CMS or others could help monitor? So I hope that helps.
No,
well, I was a little
Yeah,
surprised. Sorry, but you didn't mention price supports, because it does seem to me one of the things we could do in this case. And again, I think you were 100% right. The price is low. A slight increase in the price is going to be negligible from the global perspective. We're spending $500 billion a year on drugs. That generics are not the place where the price pressure is. Just a slight increase in the price, maybe a price support mechanism to ensure that slightly higher priced generics are appealing to the buyers might be a reasonable approach.
I thought I sort of said that, at least for the Part B drugs, where the prices really are set often at a quite low level, and getting a more expensive drug there, actually may penalize you, as long as there are other people buying the less expensive drugs. I think it's a little bit more complicated, because when you do price supports, you really want to make sure that if you're paying more, you're really getting what you want. And I do wonder about, there are organizations that have solved this problem. Talk to Intermountain Health and others that are working with Civica. They get reliable contracts. They have a greater ability to assure they're going to get reliable supply. Most healthcare organizations haven't done that. And maybe you could increase the price a bit, but I do think there's some accountability and engagement to look at on the healthcare purchaser side, where I know they want more money. I know many of these organizations are struggling, but I'd like us, if we are going to do some price support or tax incentives or things like that, that we make sure that it's going to be met with a change in behavior by the purchasers of the drugs, the hospitals, the practices, and so forth. And that, I don't think, is automatic. That's not what we've got. Good examples of success, but that's not what most purchasers are doing right now.
Wait, I want to interject with a question. I get a question.
That's what happens when you get Zeke with me. Maybe Zeke.
And I will also say that I encourage everyone to read the proposal by Richard Frank and Marta Wosińska that we published today, and we will talk about it at the next panel, because I think it does address some of these issues. But Mark, what I want to ask you is, when you talk about that there's some good actors on both the demand side and the supply side who are doing the right thing, but I don't think I heard why. What differentiates the incentives or the business model between those who are doing the right thing and those who aren't doing the right thing?
So, great question. Also, you mentioned the paper by at Brookings by Marta and colleagues. Marta's done some terrific work on all of this, and looking forward to digesting that new proposal. For those of you who are interested, Duke Margolis, which Marta's collaborated with extensively over the years, also has a supply chain advanced manufacturing consortium that has some, if you go to our website, has some relevant work in this area. So the organizations that have been more forward in going to these purchasing models tend to be the ones that are kind of thinking longitudinally about their patients. I mentioned like Intermountain Healthcare, other big systems that are really focused on how do we get to good population health, and how do we get reliable supplies and deliver consistent quality to do that. There are a lot of things you have to do well in order to deliver the best care for your patients. And somewhere on that list, many people would argue pretty high up, is reliable supply of drugs. So if you're in a health system that really is focused on systematic, longitudinal quality care, that helps. These healthcare systems have also done relatively well financially. Again, a lot of I know there are a lot of struggling hospitals right now. That might be an area to focus some more help in particular, but for many of the larger systems, cancer hospitals, et cetera, they're doing okay financially compared to others. And I don't think really, though, Wendy, we've made quality in this dimension as much of a priority for our healthcare organizations and something the American public, pays attention to when they're purchasing care, when employers purchasing care on your behalf, as they're doing for things like, well, how likely you are to get an infection in the hospital, or what's the complication rate for your procedures. This question of how likely are my patients going to your hospital, if you're an employer or a health plan, who also, could adjust some of their payments here and play a role. How likely, if I use your facility, are my patients likely to get reliable outcomes for their cancers or for their operations, because you've got reliable drug supply, and look at measures and evidence on that. I think that's important to complement any price supports or any additional payments we're making here, to really close the loop, to make sure we're changing the game. We've been 20 years of these kind of marginal manufacturers who are only in it because they can manufacture at the lowest possible cost. They're not getting a great signal from the market that reliable, well-sourced products are valued at least a little bit more. And again, we're not talking about tens of thousands of dollars per drug here. We're talking about like a relatively small amount. We're just in the wrong equilibrium with healthcare providers. And I think both sides, both on the production side, we need changes, but also on the buy side, we need changes too.
Go ahead, Zeke.
Yeah, I think one of the things that happens is, remember, Civitas was created by not-for-profits to try to solve some of this problem, as well as the insulin drug pricing problem and a few other a package of issues around pricing and supply. And those not-for-profits, some of them health plans, but some of them other organizations, push this model and recognize that there would be some costs in some areas and some savings in other areas. But I think if you think about most health systems and hospitals and ambulatory surgery centers purchases, the people doing the purchasing, they're incentivized to get the lowest price, and they're not incentivized to do other. And so while the CEO might say something about, importance of drug, when you look at the incentive structure is constantly just the lowest price. The second thing, and I think Mark alluded to this, is we don't have great data on the quality throughout the system. And so when you say we should hold people accountable for the quality of the drugs, it's very hard to do that because you don't know where these things are manufactured. Just look at the problems of pinpointing the Indian company that had this cough syrup sent throughout the world that had toxic chemicals in it and has killed a lot of children. And, chasing it back, papers get falsified. Doing the inspections overseas has been a problem and is, years behind. And so I think getting that quality data has also been a concomitant problem, unless you manufacture domestically or in countries where it's readily available. And so I think these two incentive problems are compound each other to make it hard for people to necessarily do the right thing.
But is it profitable to do? That's what I'm pressing on. Is it profitable to do the right thing? So Mark, you would describe this as we're just in a bad equilibrium, which suggests so theoretically we could just get to a better equilibrium or a different equilibrium where it's profitable and they're doing the right thing. Or is it really that we need federal policy to change incentives? Like, it's not that we're in a bad equilibrium. This is the equilibrium given how markets work.
Okay, no, just to be clear, I'm at the Duke Margolis Center for Health Policy, that the policies you set drive the equilibrium you get. So policy changes are needed here. And we've talked about some already during this session. Whether it's a for-profit or a nonprofit organization, we've seen ways to make it much more likely that you'll get quality care and potentially at a lower cost. Changes in payment are helpful for that. I just think that changes in payment that just say, well, buy more products without linking that to Zeke said, and I said, better information on who's a quality manufacturer, who do you want to contract with to get that reliable supply. Maybe think about contracts that aren't just about, how do I find the cheapest drug today, but think about contracts that are a little bit more long-term. This is what Civica is doing, longer-term contracts where you get a promise of reliable supply and some penalties on the manufacturer if they don't do that, coupled with more awareness in the public around which healthcare organizations are doing this right, are going to have the drug. If you're thinking about starting cancer therapy, boy, it'd be nice to know that the treatments that you might need are going to be reliably supplied as you go through your chemotherapy regimen. There's just not good information on that now. So I do think some new payment steps will be helpful, but in general, and I say this a lot, if you just try to pay more for more services and don't focus on quality, safety, and reliability, you're not necessarily going to get it. And so that means, making the right thing to do, the more profitable thing to do. So better information can help with that. And I think a partnership between steps at, say, FDA to help get more reliable quality information on manufacturing available, with steps with some of our payers and our healthcare organizations in terms of what they're accountable for and for reliable drug supply. That's kind of the right combination to get you to a better equilibrium.
And it sounds like, Zeke, you would say that this isn't really realistic unless we also change the location of where these drugs are manufactured.
I think that's probably true. Given the hot-cold relationship with China, I think it's a really bad strategic decision to rely on Chinese manufacturing in critical areas like our generic drug supply. And remember, 90% of our prescriptions are for generic drugs. And so it seems to me that one thing we should be wanting to do is to onshore or nearshore a lot of the manufacturing. And as we've learned, it's not just the final stages, the fill finish stage, it's also the active ingredient stage, because in India, you see this problem that they're importing all the ingredients from China. And so even if you wanted to make more domestic manufacture, if you're dependent upon the manufacturer of the inputs on China, it doesn't actually solve your problem. And that requires, rejuvenating and investing more in our domestic chemical industry. Again, there's lots of reasons that they went to China. A big one, obviously, is environmental regulation. But I think if there were requirements if there were supports for domestic manufacturing and requirements for a certain percentage of the inputs to be domestic, I think that would, to get the tax benefits or whatever for domestic manufacturing, I think that would go a long way towards rebalancing this problem. But, that requires a certain kind of investment. We've recognized in the chips area, right, that this domestic manufacturing is really, really vital for national security reasons. I don't see why it's any different when it comes to generic drugs, frankly. And they're both critical to well-functioning aspects and strategic aspects of our economy. And we're seeing the cost. I can't tell you, almost every week I get a call from someone who's either started chemo or whose chemo has been postponed because they can't get enough of critical drugs. And some of the drugs that are in shortage, like the platinum drugs used in multiple cancers. It's mind-boggling that these sort of integral drugs used by hundreds of thousands, if not millions of people, are persistently now in short supply.
I agree with mind-boggling on the persistent short supply. I do want to try to make one at least important distinction between chips and generic drugs that are potentially life-saving. Chips are, there's some additional national security issues there where there are real concerns that, you know, the US is developing technologies that have national security implications if that technology is shared inappropriately with potential competitors or hopefully not source of conflict around the world, but a lot of national security concerns there. There's a global security concern that's different around these generic drugs, which the entire planet would be better off if we had reliable supply of them. So in contrast to where I think there is going to be a continuing like trade barrier fight and maybe, you know, escalation on semiconductors and national security products being manufactured here. I think there's some common ground with other major growing exporters of drugs, India, China, et cetera, around how do we get to more reliable supply? That seems like a good area of like positive engagement for global health. And while it does seem like US manufacturing or nearshored manufacturing could provide more reliable supply easier, I'd want to make sure that any domestic incentives for manufacturing were really tied to the quality and reliability issues that we've talked about here. Just supporting, you know, more subsidies for manufacturing, I don't think is enough to get us out of what's been a persistent, you know, 2-decade problem where there have been a lot of efforts here and there to just, you know, pay a little bit more and haven't seen results. This needs a more systematic approach. And I do think there's an important opportunity for global, you know, international cooperation to get there.
I totally agree with you, Mark.
Wait. So I want to ask Mark something. Is it realistic? And maybe this was what Zeke was gonna ask. Is it realistic that we can actually assess quality and improve quality?
I think it's much harder in other countries, but that's a question for development and progress on global health. You know, many countries around the world have the potential to not only provide reliable generic drugs, but help with drug innovation as well. We're not going to get there if we don't get to a better international collaboration around what regulatory standards should be and transparency. And in contrast to semiconductors, I don't see the same barriers here from a national security and you know, trade and development standpoint. So I do think that the U.S. role here and nearshore and onshore manufacturing is going to be potentially important in the short term, but let's not lose sight of what the underlying source of the problem is. It's not just whether manufacturers in the U.S. or elsewhere. It is the manufacturing reliable, and do we have reliable ways of measuring that? And can we engage our healthcare purchasers in paying a little bit more to buy that and get us to that I can't believe this. I'm saying you know, new market equilibrium 4 times. It shows you it's a Hamilton project event.
Zeke, did I ask the question that you were going to ask?
To some degree, I would say, look, we do have standards, global standards on good manufacturing process, and we do know when the manufacturing process goes off the rails because the FDA does close production lines that are contaminated or not meeting standards. So I don't know that it's a standards problem so much as it is a problem of ensuring that the standards are met, which does require inspection on a regular basis, even without problems. And Mark's 100% right. I was going to say, we have to remember it was COVID. We had problems with manufacturing domestically COVID vaccines at Catalent and others that had contaminated lines. This has been something we've known about. And I think Mark is right. Just because it's domestic doesn't make it high quality. We have to have both or all three: domestic, high quality, and the willingness to pay the marginal extra cost for these good, high quality production processes. And that is going to require legislation and regulation. And I think that's something we shouldn't kick down the road for another 20 years. And you know, I do think one of the advantages of the moment is the turning up of the political pressure. What we haven't had is a very clear package of this is how we can solve the problem for the foreseeable future. And I think this is where Marta and others really can make a great contribution for us.
Yeah, I'm looking forward to that further discussion. In the scheme of things, the big challenges that we're dealing with in healthcare, public health, everything around the world, this one is relatively inexpensive. It does take, it's not just FDA regulations, it's not just better information, it's not just paying more and more subsidies. It's not just what healthcare providers are doing in their purchasing decisions and how they're being held accountable and transparent for that. It's a combination of those, but it's I think it's relatively doable in the scheme of problems that we have to deal with these days.
So, Mark, I know we're going to lose you in a minute, and then we're going to give Zeke the last word in this discussion. So, knowing that Zeke's going to get the last word, is there anything that you want to say before we have to say goodbye to you?
No, I just said at least in part he agreed with me 100%, and I think I got in my last word a minute ago. This is not easy. It's not just like point at one specific regulatory issue or one specific additional source of payment, but a combination. But I think we have a pretty good idea of what can work, and hopefully, I think there's a pretty good chance for bipartisan consensus, support from across the administration to make these changes happen. And it's high time to do it. And maybe I should say, Zeke, hopefully you agreed with all that too. I'll see you all soon. Thanks for doing
Thank
that.
you very much, Mark. All right.
Let me pick up on that last point. If there's anything that distinguishes or that the Biden administration puts its stamp on and identifies with in terms of healthcare, it really has been their drug policies. And this fits squarely in that portfolio, it seems to me, of making major strides towards fixing the drug business, as it were. And so I think their interest in addressing this is adds to the collection of things on the drug side that they've done. And I would not be surprised that they come out very strongly in the next year on this. And, it's something that certainly in the White House, they understand. And I think at HHS, they understand.
So you see no inconsistency between what you're calling for here and the action, the policies that are incorporated into the Inflation Reduction Act with regards to drug policy?
So we should remember, I think it's 90% of prescriptions are generic, plus or minus a few percentage, and they account for 20% of the spend on drugs. 10% are brand name and increasingly biologics, and they account for 80% of the spend. So the cost is in all the things that the Inflation Reduction Act and drug price regulation has put the target on. This is, it may change the drug spend a few percentage points, 1, maybe 2 percentage points, but that's not where the money is, as they say. This is where the supply issues, the demand issues are. So I think and Mark said this well, this is cheap. By any stretch of the imagination, this is very cheap to solve. And I don't think, again, bringing production onshore, bringing the active ingredients more onshore is going to be a big cost problem to the health system at all. And if the projections are right, and my sense is the projections are probably a little low about how much we might save from the Inflation Reduction Act, more than compensate.
Oh, I see. That's so they're what the Inflation Act we're doing. I mean, I just wanted to clarify this for our listeners, right? So what the Inflation Reduction Act is doing is it's addressing completely different problems in the drug market. And in fact, in a sense, they're problems that go in different directions in terms of costs.
Yes. And, the Inflation Reduction Act predominantly is trying to look at the problems of the brand name drugs and regulate the high price. They do have that provision that penalizes manufacturers for raising drug prices in excess of inflation. And Mark got to this. We might have to ease that up for generics under a certain price because you might have to raise the prices more than inflation. You might even have to double, but doubling a $10 or $20 drug is not what's going to change the system from a price standpoint here. It's not going to have a really market impact. And I have in other places personally said we're probably, for many generics, paying too little. I made this argument about antibiotics and antivirals and anti-infectious disease items. We're probably paying too little for them when they're off patent. And again, I think thinking about price supports here with quality guarantees, as Mark emphasizes, is quite a reasonable approach and something we should take very seriously.
All right, so last question before we turn to then our panel discussion. Much of what we've talked about has been super alarming and should probably scare the socks off of anybody listening. But I think my takeaway is you have optimism that these problems are solvable and that there is momentum to solve them. So is that right? And can you leave us on a point of optimism?
Oh, absolutely. So Wendy, I would put it this way. John Kingdon, who was a professor of political science at University of Michigan, argued that, you get change, you get legislation when three things come together. Public interest, this is a really serious problem. Well-vetted programs, and then a policy window. I think the public is really clear that this is a really serious problem now in a way that they probably weren't 10 years ago when I first wrote about this, and 20 years ago when Mark mentioned problems around certain drugs. So you got the public attention. We have vetted programs, and Marta's going to talk about ideas. I think the combination, as Mark puts it, the combination of fixing the supply chain, nearshoring or onshoring production, making sure we have quality and we can grade the quality and people can be aware, making sure that the demand side is will pay more. All of those things, I think, the combination, we might disagree a little bit, but it's pretty clear that you have to address the whole range of it. And the policy window, I think, is open. The policy window is open because the administration has made drugs its emblematic healthcare issue. The policy window is open because the public is really experiencing these drug shortages personally every day, whether for themselves, their relatives, their children. So I think that's what makes me an optimist. John Kingdon's three streams model makes me an optimist here that we can address this problem finally and actually put it on a solid footing going forward.
Excellent. Well, thank you so much, Zeke. And thank you to Mark.
Wonderful to be here.
Yeah. All right.
Brookings program again.
Excellent. All right. So I would now like to transition to our next discussion. I am happy to introduce Marta Wosińska, who is a senior fellow with the USC Brookings Schaefer Initiative for Health Policy, and Brian McCormick from Teva Pharmaceuticals, where he is vice president, chief regulatory counsel, and head of global regulatory policy. So very quickly, I want to establish some facts about shortages. There are 300 to 400 different generic sterile injectables, which I'm betting you're going to hear called GSIs. So earlier this year, FDA reported a whopping 77 were in shortage, and there are consequences. In 2009, a shortage used to treat Hodgkin's lymphoma in children reduced the subsequent 2-year survival rate from 88% to 75%. And as alarming as that kind of statistic is, the effects on hospitals' bottom line is pretty small because of how hospitals are paid. So Marta cites recent research in her paper that hospitals only incurred about $365 million a year in extra labor costs and $230 million in extra drug payments. So obviously the costs to society are way in excess of what sounds like really paltry numbers in the context of the whole hospital system. So Brian, let's start with you. What do you think are the causes of these issues?
Thanks very much. And thanks very much for having me. It's a pleasure to be here. Again, from Teva Pharmaceuticals, although I'm here in my individual capacity. I think this conversation with Dr. Emanuel and Dr. McClellan, I think, we're getting now to a discussion of the root cause of the problem. And you're seeing this more now in the trade press and op-eds and the articles that are being written, and certainly the Hamilton Project's paper that we're going to talk about more this morning has all of this in it, right? Which is to say that the root cause of the problem is the lack of financial sustainability in the generic drug marketplace as it stands right now, right? If you just Google it and you ask FDA on the web, why are we having drug shortages? What is the cause of the drug shortages? The agency is still maintaining that quality issues or manufacturing issues are the cause. Again, quality and manufacturing issues are not the root cause. The financial situation in the global generic drug industry is the root cause. I think the paper and the discussion really here today is really making that very clear. That lack of financial sustainability, and as an industry, our inability to sustainably manufacture these products, that is what is causing product discontinuations. That is what is causing, the repercussions of, underinvestment in safety stocks, underinvestment in new manufacturing technologies, capital expenditures, the move, as we were talking about earlier this morning, the move to jurisdictions like India and China, right? It's the financial sustainability. And so that's why it's incumbent upon us to target our solutions to the problem, right? To the lack of financial sustainability in the global generic drug marketplace. And I describe it like that because if you're not attacking the root cause, if you're attacking, say, quality issues, or if you're saying, if you're attacking offshoring by mandating onshoring or nearshoring, or if you're mandating safety stocks or something like that, you're making the problem worse because you're not attacking the root cause of the problem, which is the lack of financial sustainability in the global generic drug marketplace. So, so we need to get to that. Otherwise, what you're doing, in the policy choices, is you're adding costs to an already overburdened industry, and we want to make sure that we don't do that unless we're going to get the benefit by attacking those root causes.
So that's helpful, and I know Marta is going to have a lot of thoughts on what you just said. But first, Marta, tell us about your proposal. Tell us how you and Richard propose solving these problems.
Thanks, Wendy. So our proposal, as Mark said, we need a comprehensive, come at it from multiple angles solutions, and our proposal is coming from multiple angles. It has incentives for manufacturers and for improving infrastructure. But perhaps and it has also buffer inventories to serve as insurance. But probably the most important element in the proposal is aimed at hospitals in trying to address in how they buy and how they procure product. And just kind of, I want to tie that to the comment that Brian said. There is actually a connection between price and quality. So yes, we have a race to the bottom, and that's what makes it so unsustainable for a manufacturer. But that race to the bottom does result in deteriorating quality, which in turn leads to disruptions in production. And so what we are trying to do in our proposal is realign hospital incentives so that they put less emphasis on price and more emphasis on reliability. And we propose to do that through a CMS program, a pay for performance program, similar to actually a number of other CMS programs that they have put in place. But the key is to connect, to have this element of reliability and putting basically more weight on that relative to price.
And Brian, I know you've been able to look at the proposal. So what do you think? Does this work?
Yeah, I mean, I think all aspects of the proposal are very interesting. I appreciated the paper very much. And the other aspects about support for infrastructure and the buffer inventory proposals, I think, are also worth discussing. On this side, on an initial read, I think the fear is that increasing the funding to the hospitals, we need to ensure right, that we have a way to trickle those funds up to the manufacturers, right? We need to make sure, if the goal here is to put manufacturers in a financial situation where they can onshore or nearshore, invest in new manufacturing technologies, invest in safety stock, and better secure the supply chain, we need to make sure that, you know, additional revenues going to the hospital sector are flowing upwards toward the manufacturers. You know, I think one problem there is that because of the complexity of this ecosystem, you have all of these constraints on manufacturers to take price increases. So it's very hard, and I'm not an expert on the reimbursement system by any means, but, you know, it's very hard to see how the additional revenue here going to the hospital flows up, given, you know, Dr. Emanuel raised it, you know, restrictions in the IRA on the ability of manufacturers to take price increases, the 340B program. You know, we have a real growth in all of these diverse state laws that are constraining the ability of manufacturers to take price increases, even on very, very inexpensive generic drugs. And so if the manufacturers can't take the price increases, you know, I'm not sure that I see how we're going to get that money up. And I think the other one reason why we're in the situation that we've talked about a little bit in the earlier session that I think is also worth just underscoring is that the hospitals and the purchasers throughout the chain, they're taking as a given the quality of the medicines that the FDA allows onto the market and gives access to the American consumer, right? And so we want to be clear about that. All of these medicines are what we would call GMP or GMP compliant, right? You know, the agency has lots of proposals that we'll talk about quality metrics and quality management maturity. All of those things are essentially a higher standard than the fact that FDA is ensuring that all of the medicines on the US market, and we all believe this, and this is true, are of sufficient purity and quality and potency to make them safe and effective medicines. And the purchasers know that, as they should, and they're taking that as a given. And so that is why they're competing almost entirely on the basis of price, right? That's how they're making their purchasing decisions. So it all comes down to the price. And if the manufacturers can't increase the prices they charge, I don't know how we get this money back up from the hospitals.
So Marta, Zeke had talked about how little transparency there is on quality. And this is something you focus on and try to solve in your proposal. So I'm guessing you're going to say that you agree that there's little transparency. So I'd like you to describe why that might be true and how your proposal really tries to get at that.
Thanks, Wendy. But if I could first just follow up on what Brian said. So our proposal does two things. We're trying to steer demand away from manufacturers that are not reliable and towards manufacturers that are. And also, we do think that there's room for price differentiation among manufacturers. One thing I wanted to say about the IRA, and there have been concerns that maybe IRA might actually penalize manufacturers for raising prices. The kinds of drugs that we're talking about are actually exempt from inflation rebates. So I think the IRA is really not a threat in this context. And also, you know, generally these drugs are used in inpatient, are actually bundled and they're not separately reimbursed, except for clinics and in the outpatient setting. I do agree that there's potentially more friction on that side of the market, on the outpatient side, in the ability to increase prices, but not for the inpatient side and the IRA. But now sort of coming back to your question around transparency, my answer is yes and no. I do think we could have more transparency, but I think transparency as a barrier has been overstated. There are efforts to increase transparency, they're just not being embraced. You know, again, Civica that Mark talked about, they do homework on who they contract with, right? Not all the plans are participating in it. US Pharmacopoeia has a supply chain map where you can actually find out specifically which facility is producing which product. It's available. It's not being widely used. There is an organization that's been trying to set up a rating system, a nonprofit called Risks, to try to basically look at the resilience of supply chains. It's not being adopted. I think we could do more to provide transparency. I think QMM that we discuss, quality maturity metrics in the FDA could really advance the field. But I do think that there's a lot of information available currently, but these efforts to create more resiliency are just not being adopted because there's no financial incentive to do so. Again, the weight on reliability versus price is off. So my answer is a bit of a yes and no.
So Brian, do you agree? Does Teva Pharmaceuticals have a way to communicate to buyers that it's potentially more reliable or higher quality than competitor suppliers?
Yeah, absolutely. I mean, and I think that's one of the concerns about the quality management maturity proposals coming out of the agency is, my knee-jerk reaction to it, number one, is to question the necessity for just exactly the reason Marta was just describing. As we know, we have very few customers. Basically, right? I'm not, the numbers are all in Marta's terrific paper, but, again, we have 3 GPOs that account for 90% of drug purchasing in this country, right?
Pause on that, because I'm betting that people don't understand that. So, because that's a really critical aspect of this market. So can you just
right,
that a little bit?
Absolutely. So, as the paper describes, there's the number of purchasers of our drugs in the system has declined significantly, right, through GPOs and through buyer consolidation, right? So now the 3 large GPOs, the names of which I can never remember, account for 90% of the purchasing in the marketplace, right? So we essentially are selling our drugs to an extremely small number of extremely sophisticated purchasers. And so on the transparency point, this is why, when our relatively few, very sophisticated customers want additional information about our quality systems and our practices, they absolutely can and do ask for it. And so I question whether the QMM proposals you see out of the agency are necessary. As a lawyer, I question whether the agency has the statutory authority to require it. The lawyers are always going to look back to the Food, Drug, and Cosmetic Act and look for the underlying power that the Congress has given the agency to do it. But then the third thing gets a little bit closer to Marta's paper, which is one of the things that frightens me a little bit, is that the proposal is designed to steer demand towards more reliable manufacturers. And I think that's something we can all sort of agree on. I think that's something we all think is a really important goal here. I think the problem is, to sort of say it a little provocatively, in a QMM context, manufacturers with low QMM scores are critically important to the marketplace, right? In other words, one of the fears here is that you have an older generic manufacturing facility with an older manufacturing line that is nonetheless producing at a relatively low cost. Again, GMP, pure high quality medicine for the US marketplace. And if we're not careful with this QMM proposal and we steer demand towards manufacturers with higher QMM scores, we're going to drive lower QMM scored facilities and companies out of the marketplace. And query whether what we want is fewer high QMM score facilities, or do we need more diversity in the marketplace, in the manufacturing system, right? We don't necessarily just want one US domestic maximally QMM scored manufacturing facility, because a tornado can hit that building as well, right? So what I think we need is a more robust, diverse supply chain. And again, because of the assurance of GMPs, of good manufacturing practices, because the Food and Drug Administration is the world's gold standard in ensuring the safety, efficacy, and quality of our medicines, and that's absolutely true. All of these medicines that we're talking about, including the ones coming out of low QMM squared facilities, are absolutely appropriate. They're pure, they're potent, they're safe, and they're perfect for the US market. And I'm I don't want to increase the instability and increase the shortage issues by driving a low QMM facility out of the marketplace.
So I
know you have thoughts. Go ahead.
I have thoughts. So let me first explain why we do think QMM. So let me just, why QMM is something that we would like FDA to advance. And the reason is that GMPs and, past inspection are really backward-looking data pieces that, again, we talked about. They can be observed, but they're not necessarily complete. Not every facility is inspected at all times. QMM is a forward-looking measure. It's about it's about how proactive the company is in resolving problems. It actually puts a lot of emphasis on quality culture. Let me give you another sort of a perspective here around GMPs and sort of the incentives that manufacturers face. Think about speed limits. You're a driver, there's a speed limit. If there is a camera, the probability of being caught is 1, right? So you're going to slow down. Let's say there's no speed camera, but the penalties are really high. You're not going to speed if you know the penalties are really high. If neither one of those are high, a lot of people will speed, but not everybody. And then not everybody is what I think of as the quality culture. And that's why some companies, they do have the quality culture. And that's in a sense what QMM is trying to get at. So that you know that despite sort of the pressures, the company is not going to cut corners and they are going to follow these good manufacturing practices, but you do it in a way that you sort of capture it as a sort of a more holistic concept. Now, FDA is not there yet they've been trying to develop it. They have a pilot. What we propose is that they continue doing so. We think they need money from Congress to do that. And we would encourage them to do that, specifically focus where the biggest problem is, which is generic sterile injectable facilities. Now, Brian, to your point of, FDA might not have the authority, we actually don't want this necessarily to be a mandatory program. If a manufacturer feels like they actually have good systems, they can participate in this, they can get a high QMM rating, and hospitals would be rewarded for purchasing from them. But in terms of the players that are not QMM, this is why we have component 1, right? We will give them an incentive. Like, it's true, maybe you will need to go out, but there's going to be an increase in demand and incentives to increase capacity for the higher QMM. And at the same time, we'll have an incentive for the lower QMM manufacturers to also potentially change and adapt. So, I know that we would like to say that everybody is meeting GMP standards, but the probability of being caught and the consequences of being caught are not high enough. And so that's how you end up with this situation. And that's why we want to be thinking about quality culture in these manufacturing facilities.
Yeah, so I think we definitely agree on the necessity of the quality management maturity proposals and pilots to move forward as voluntary programs. I do think that the agency would make clear here that QMMs and GMPs are not the same thing. I think that the agency has great degree of confidence that the medicines on the U.S. market are GMP compliant. I agree. Quality management maturity is a proposal to try to develop metrics to be more forward looking. And so I think we definitely agree with that. As to I won't belabor the authority point. As I mentioned at the top, I think your other proposals in the paper merit a lot of consideration and discussion as well. I note in the paper that whether it's the forgivable loans for manufacturing and infrastructure improvements, it seems like your proposal would forgive those loans if those companies are participating in the QMM program or have QMM scores. And similarly, your inventory buffer program in the proposal as well, you propose to purchase inventory from QMM scored facilities. And so again, I do worry about a manufacturer that isn't participating in the program, maybe because the age of the manufacturing line suggests that it might have a low QMM score, or if it does participate, it does actually receive that kind of low QMM score. And again, my point is that I want a facility with a low QMM score on the US marketplace because I want as many adequate suppliers available to us. And again, I want to support that facility in increasing its quality metrics and increasing its quality programs. And I want to give them the resources that they need to do that. Again, that's why, I think we need to address the price, the revenue issues that Drs. Emanuel and McClellan were talking about as well. But, I think the QMM score, the QMM proposals that I've seen from the agency are as likely to have some negative repercussions as the positive.
That's right. But Brian, what I don't want is that facility to have 50% of the market share, because they are going to be more likely to have a problem. So the idea is to, shift demand towards the ones that are more reliable, because otherwise that's exactly how we end up. The manufacturers that don't have the systems that are, as reliable are the ones, because of price, get very high market share of product. And that's how we end up with shortages.
All right, so Brian teased many of the critical aspects of your proposal that we really didn't have a chance to fully flesh out here, so I encourage everyone to look at it again. Marta, I want to give you the last word and ask you, do you share the optimism that we ended with on the last discussion?
You know, I do agree that the window is open right now for policy. When we have seen Congress really step up is in time of crisis. I think we're in a time of crisis with the number of shortages that are happening and how and where those shortages are happening. It is also a bipartisan issue. And relatively speaking, it's not nearly as expensive as a lot of other things that we're trying to fix. So I am hopeful, maybe not optimistic, but I'm hopeful.
All right, I'll take that. All right, so on behalf of my colleagues at the Hamilton Project at Brookings, thank you to everybody who's joining us online and watches this later. And thank you so much to Brian McCormick and Marta Wosińska and Richard Frank, who is not here, but helped to co-author the policy proposal that we published today. This has been a fantastic conversation. Thank you for your time. And let's have guarded optimism.